Good afternoon, everyone, and welcome. My name is Nadia Rosen. I'm the CEO of Head and Neck Cancer Australia. I'd like to welcome everyone and thank you for joining us for our third Head and Neck Cancer Outreach webinar for 2021. We're very grateful for the funding received from the Western and Central Melbourne Integrated Cancer Service in Victoria that has allowed us to host this webinar series. For those of you who may not be that familiar with us, Head and Neck Cancer Australia is the only charity in Australia dedicated to supporting people with head and neck cancer. Head and neck cancer is a complex set of cancers that includes 10 different types that can affect a person's mouth, their tongue, throat, voice box, salivary gland, just to name a few. There are over 5,100 people who are diagnosed with head and neck cancer every year in Australia, and more than 17,000 people living with the side effects of treatment. Today's webinar is all about laryngeal cancer, also known as voice box cancer, treatment for laryngeal cancer and living life after a laryngectomy. We couldn't deliver such high quality educational events without the support of our presenters. And today we're privileged to have Alanna Bowen and Tracey Nicholls joining us. Both Alanna and Tracey are highly experienced head and neck cancer healthcare professionals with advanced skills in laryngectomy management. We'll tell you more about our speakers shortly, but I'd like to hand over the hosting of today's webinar to Julie McCrossan. Julie is a former ABC journalist and radio host and was treated for head and neck cancer in 2013. We're very lucky to have Julie as one of our ambassadors, helping to raise awareness of head and neck cancer and working tirelessly to improve patient outcomes. Thanks, Julie. Over to you.
Hello, and thank you so much, Nadia. Hello, everyone. As Nadia said, my name's Julie McCrossan, and it really is a genuine pleasure to be your MC today. And welcome if you're just joining us. I think people are coming in even more now to this Head and Neck Cancer Australia webinar, information and support for people directly affected by either having a laryngectomy or someone that you know and love has had a laryngectomy. And this is the third of 4 webinars. We will have another in the series in December. And I too would really like to thank the Western and Central Melbourne Integrated Cancer Service in Victoria for their support. I was treated for stage 4 oropharyngeal cancer, tonsils, tongue and throat back in 2013, and I had radiation and chemo. And so I say that partly to, offer that hope to anyone who may have had a recent diagnosis that we have a very good rate of survival and survival care in this country. I want to acknowledge that I'm broadcasting to you on Aboriginal land, the land of the Kaurna people in Adelaide. And I know we have people from all over Australia, and indeed we have a number of international viewers today. I'd also like to extend a special welcome to anyone who's recently had a laryngectomy, because this is really all about you and your family. And we will be joined just towards the end of our session by Mike George, one of our ambassadors who's had a laryngectomy, and he'll talk to you about his life after this experience. Some key messages, some housekeeping, and then off we go. Nadia has outlined the key things, but I guess 14 people a day in this country get a head and neck cancer diagnosis. And as you're probably aware, there is no screening test. And we also know that early detection saves lives. It can also lead to less intrusive treatments and a more rapid recovery and hopefully fewer long-term side effects. So how do we get early detection without a screening test? Well, we spread the word about the signs and symptoms. And so we would be so grateful if you could go to the Head and Neck Cancer Australia website to look at the 60 fact sheets that are there, the multiple videos with both clinicians and patients. We have the previous webinars in this series and other relevant webinars, and a really marvellous webinar with patient and clinical expertise on intimacy after treatment for head and neck cancer, produced by VCCC Alliance, another amazing collection of organisations and research and clinical organisations in Victoria. So we ask for your help to spread the word so we get more early diagnosis. Just the housekeeping. In order to ask questions, and we will have questions at different intervals during our session, please put them in the Q&A. Just write them in the Q&A and Nadia will monitor them and we'll answer as many as we can. questions we can't answer, or if there are questions that go into detailed individual situations, we'd recommend Cancer Council Australia, their information and support line, 13 11 20, 13 11 20, and they are most helpful and can refer people. And finally, just another reminder that our final webinar in this series will be in December, and we'll send you information. So just before we begin, we've got a poll. Now, there are 4 questions in this poll, and we need you to answer all 4 of them and then click the submit button. And in order to see all 4, you'll need to scroll down. They're all in one go. So I'll ask Nadia, our tech queen, as well as our question moderator, to pop them up on your screen. I'll be quiet and I'll let you know when I'm coming to the point of, thank you very much, Nadia, we can now see them. So would you please answer 4 questions, remembering to scroll to the 4th question. And the first one, which best describes you? I'm a head and neck cancer patient. I'm a former head and neck cancer patient. I'm a carer, family member, or friend of a head and neck cancer patient. I work in allied health. I am a nurse, another healthcare professional, or other, e.g. medical industry. Please click the one that best describes you. Question 2, is a laryngectomy reversible? Yes, no, not sure. I now move to question 3. Can a person with a laryngectomy breathe through their nose? Yes, no, not sure. And our 4th and final question, can everyone with a laryngectomy speak? Yes, no, not sure. And once you have answered each question, please click submit. Well, I'm going to proceed now and ask Nadia to show us the results, please, and I'll share them with you. First question, which best describes you? 18% are patients, 10% former patients, carers, family member or friend, 4%, allied health, 38%, nurse, 19%, other healthcare professional, 8%, others, 4%. Thank you so much. I'll now see if I can scroll down, yes, to question 2. Is a laryngectomy reversible? Yes, 2%, no, 78%, not sure, 20%. Can a person with a laryngectomy breathe through their nose? Yes, 11%, no, 74%, not sure, 15%. And finally, can everyone with a laryngectomy speak? Yes, 22%, no, 55%, and not sure, 23%. Please click your close button. Look, thank you very much, and that will be of great interest to our speakers. So let's begin with our speakers. Our first speaker today is Tracey Nicholls. Tracey is an ENT, ear, nose and throat nurse practitioner and a head and neck cancer coordinator with SA Health, South Australian Health, and she's based at the Flinders Medical Centre in Adelaide. She's a former president of the ENT Nurses Group for 11 years, and she started a head and neck cancer support group for patients and family back in 2016. And can I say, Tracey is a tremendous friend of head and neck cancer patients and their families and offers enormous group and one-on-one support and advocacy. This includes setting up a walk-in clinic for patients with difficulty speaking, also known as spasmodic dysphoria, And she's travelled all over Australia and indeed to the United Kingdom and the United States to meet other nurse specialists in this field. So using deaf sign clapping to give warmth in cyberspace, welcome to Tracey Nicholls.
Thanks, Julie. Welcome, everybody. Okay. There we go. Okay. Thank you, Nadia and Julia and Head Neck Cancer Australia for giving me the opportunity to speak on a topic and a subject that's very dear to my heart. Unfortunately, I could take all day, but I've got 10 minutes. So here we go on our Cook's tour of laryngectomy. We'll briefly go over surgery for laryngeal cancer, post-surgery changes, touch on humidification, suctioning and mucus, and what to do in an emergency procedure. Alanna will then come in and talk about voice prosthesis and speech, and then I'll come back with a life after laryngectomy, covering lymphedema, financial, intimacy, travel, anxiety, depression and survivorship. An awful lot to do in 10 minutes. So what is a laryngectomy? So a laryngectomy is the surgical removal of the larynx. This is usually due to cancer, but can be caused by trauma. The surgery separates the trachea from the esophagus and redirects the windpipe to a permanent opening in the neck. This is called a stoma. It's not the same as a tracheostomy and should not be referred to as a tracheostomy. Yes, it is an ostomy. It does involve the trachea, but there is no longer any sort of communication with the upper airway. They are referred to as neck breathers. Now, a neck breather means that there's no longer air that passes through our inbuilt humidifier, filter and moistening units, so our nose and sinuses. A laryngectomy patient breathes directly through the stoma in their neck. Usually caused, as I said, by a glottic cancer. This could be, the first picture is above the vocal cords, the V are the vocal cords. It could be a cancer in the vocal cords or just below. So if we have a look at the larynx, and I'm not sure, I hope you can see my mouse, but if we go to the picture in the middle, and if we come through the mouth, we can see the tongue. We come down, we've got base of tongue, and then go into what we refer to as the larynx. This big bit of cartilage is the thyroid cartilage, or Adam's apple. And if we go to the picture on the left, we can actually see the base of tongue, our epiglottis and our vocal cords. And when we swallow, the epiglottis closes, the vocal cord closes to protect our airway, and food and fluid travel down and into our esophagus, our food pipe. The picture on the right, obviously our tongue base, our epiglottis, the vocal cords, just seeing the windpipe behind, and then our esophagus sits just at the back here. So I think this graphic really shows it really, really well. The first picture shows what we remove in surgery, and the second picture bringing that trachea up to the skin and sitting on the neck. So post-laryngectomy changes means that the upper airway is irreversibly changed, that there's a loss of voice, and that's due to the removal of the vocal cords. There's an impaired ability to cough effectively. And that's because when we normally cough, we're able to hold our breath, increase that thoracic pressure, and do a forceful cough. Laryngectomy patients can cough. It's not as forceful as what we are able to do. They cannot sneeze or blow their nose, and that's because the expired air is coming through the stoma instead of through the normal systems. Swallowing difficulties, and that may usually due to surgery or radiation, and that may require ongoing esophageal dilatation. So that's an admission to hospital and surgery, and that could be every couple of years that's required. They certainly need good artificial humidification, and that's essential to keep their secretions nice and free and loose. The sense of smell and taste are diminished, and that's because no longer there's that turbulence of air going through the nose, and that's where our organ for smell is situated. There's an increased risk of pulmonary infections. There's certainly a risk of foreign body inhalations, but certainly a laryngectomy patient will never aspirate. Difficulty in picking up heavy objects, and that's because we do that Valsalva, we do that holding our breath so that we can actually put some force into picking up heavy objects. And there's an open tract between the neck and lungs, so there needs to be a lot of care when showering or near water, and certainly no swimming, although I have known a couple of laryngectomy patients that swim. So surgery, so all surgery has complications, and that's because of all the drugs we use. There's anaesthetic risks, there's wound infection, but in particular to a laryngectomy, there's a thing called a chyle leak, and that's due to injury to the thoracic duct. So that's the system that drains all the fatty and extra fluids out of the tissues, and of course muscle and nerve damage. Most often it's coupled with a modified radical neck dissection, especially if we've got positive lymph nodes. Depending on how much tissue is removed, that needs to be replaced. And then depending on the surgeon and the hospital, whether we do a thing called a primary or a secondary TOF. And that's a tracheoesophageal fistula, which is surgically made to enable voice down the tract. But Alanna will speak more about that. So as I said, when you take tissue away, we need to fill it with something. And more often than not, there's two types. We can use these, what they call a free flaps, and it could be a radial forearm flap. And this is the vessels, arteries and veins that come with it, or a thigh, tissue taken from the thigh. But more often than not, we use a rotational flap, and this is called a pec major flap. Really important, and especially with the flaps that have been placed in very delicate areas. These days we're actually able to use a thing called an implantable Doppler, and what they do, they attach to the vessels and they let us know an audible sound if there's any sort of problems and those vessels stop flowing. So it's important not to put any restrictions like Velcro straps or cotton ties, and then to notify the surgeon immediately if those vessels are compromised, even in the middle of the night. This is really important. So hospitalisation usually depends, usually in ICU for 2 or 3 nights, then into a high dependency unit, and then into the general ENT ward. Admission can be 10 days to 10 weeks or even longer, and that depends on what actually happens after surgery, if there's any chyle leaks or the wound breakdown or any sort of situation that may occur. Obviously we'll have wound drains, urinary catheter, and then different arterial or intravenous lines. Our patients have a nasogastric tube in, and that stays in situ for nearly 10 days because we don't allow the patients to swallow, so nil by mouth for approximately 10 days, all going well. But I think the most important thing is that there is no voice. The only communication occurs by gestures or writing, and that's fraught with a lot of different issues as well, or there's things like these picture boards that may be used. It's really important that there's some identification above the bed that this patient's actually had a laryngectomy and that they cannot be intubated or oxygenated via the mouth. There's a nice diagram as well that can kind of give you a visual about what's happened. But I think more importantly, it outlines the emergency equipment that needs to be by the bed, and this needs to be checked on a daily basis. I think because I haven't got a long time to talk, I think one of the things we need to cover is secretion management. And it's just because now the air has only got a very short way to go before it gets into the lungs, and it needs to be warmed. Normally when we breathe through the nose, it travels through our sinuses, and by the time it gets to the lungs, it's at body temperature. We're breathing straight through the stoma in the skin, so it hasn't got a long way to go. In hospital, we can do things like actively humidify the air. We use a Fisher & Paykel Airvo 2. We'll do an inline saline nebulizer as well. And some hospitals will even pop the patient on a heat moisture exchanger, which is this diagram down the bottom, which we'll allude a little bit more to as we go through the talks. Tracheal suctioning becomes very important. This needs to be done very gently. I would imagine this would be quite traumatic and quite strange to those early days when that feeling is very sensitive. You need to assess volume and colour, you need to document the frequency, and then of course if you will come across any obstruction. So complications of surgery, I've left this in, not going to go through them all, but Nadia will give you access to these slides just for reference later down the track. The other thing I want to talk about is a mucus plug. And now mucus is the body's way of protecting and maintaining the health of the trachea and lungs. If it becomes thick and sticky, one of the things it can do is form a plug on the trachea. And if that's not cleared, more mucus is produced, and that can add to that plug. And hopefully it can be a sudden and unexplained shortness of breath. If so, it becomes a medical emergency. And if you're at home, dial 000 and let the AMBOs know that this is an airway emergency. Sorry about the graphics on this. These are a couple of mucus plugs that I have removed. This one on your right was round about 6 centimetres in length. So we've probably only got about 11 to 12 centimetres before we hit the carina. That's where the lungs divide. So this occupied half of the trachea. The only good thing about it is that it actually had a lumen, so there was a bit of air that was getting through. These are deadly and they need to be manually removed. In an emergency with a laryngectomy patient, healthcare professionals need to know that there is no upper airway. The only airway is through the stoma. Oxygen suction, intubation and resuscitation is only via the stoma. And for the best seal, especially if you're bag venting, is the 60mm pediatric round mask. So it's a neonatal resus mask. So I'm just about to finish. Once all this is done, and usually we wait around about 6 weeks for healing, and then patients are represented at our MDT, so that's the multidisciplinary team meeting. All patients are presented before we start treatment, during and after. And what we discuss is whether the margins are positive or negative, if there's been any capsular spread, so the cancer's gone beyond the lymph nodes, or if it's followed a nerve pathway or a vessel pathway, then we would recommend chemo and radiation. Thank you.
Thank you so much, Tracey, for that excellent presentation. And I just want to reassure our viewers that you will be sent a full copy of this webinar. The slides are available, and it will also be posted on the Head and Neck Cancer Australia website. And please share it. And I just want to thank you for coming to this webinar and taking an interest in this extraordinarily important area. We're going to take 5 minutes for questions. We're beginning with an email we received from a patient, and this is from Michael Kennedy in Canberra. I'm a patient. I had a full laryngectomy and a partial pharyngectomy in May this year, so I am 5 months into my journey. To keep it very brief, I would like to say that my biggest ongoing symptom is frustration. The pain can be medicated, and yes, the frustration can be worked with, but it appears every day. I thought I knew what it would be like with no voice and the other health issues, but new things come up every day, and these are things I can't solve. I'll get through it with patience, but right now it's exasperating. I'm frustrated that, one, I can't be spontaneous in conversation. I have aids, but it's hard not being able to be immediate in conversation. 2, I can't shout to my grandchildren to keep them out of immediate danger. 3, I can't call or whistle my dog. 4, I am frustrated, the amount of time that dealing with my health requires every day. 5, I'm frustrated that I'm frustrated. I'm happy to be alive, and I thank everybody that has helped me get this far. Thank you, Michael. A quick response, Tracey, because I know you know so many people. What would you say to Michael?
Oh gosh, immediately, I don't think anyone really understands what each individual goes through. And what is really important to you may not be important to the next person. And I think it's a very individualized thing. And I think the further you get through your journey, it's those little things that make it more frustrating, I guess. You're over the cancer, you're over that immediate, I've got cancer, what am I going to do? That you start trying to find how you're going to live every day. And I don't think anyone can underestimate the inability to communicate spontaneously. It's devastating.
Look, thank you. And Alanna Bowen, I acknowledge your presence. Our next speaker, who I'll introduce shortly. I might, because of our limited time, go straight to a question from the audience, if I may. Nadia, a question, please.
Yeah, sure. So, Tracey, someone just put a question in the chat saying, can you cover the need to puncture a TEP?
Can we cover the, sorry?
Can you cover the need to puncture a TEP?
Alanna's probably going to cover that in her talk, actually.
Okay. Well, look, may I come to Alanna, just because it's been asked now. Alanna, welcome. This is our speech pathologist speaker. I'll give you a formal introduction in a moment, but would you just give a quick response to that question?
I think what the question
and explain what the question is.
Yeah, I think what the question, or my interpretation of what the question is asking, is why do we need to potentially puncture for a TEP?
And what is a TEP?
Yeah, TEP is one variation of several acronyms which refers to the hole where the voice prosthesis sits. So we need to create a hole between the airway and the esophagus to be able to use a voice prosthesis so that communication can happen via that particular route. It's one option for communication following a laryngectomy.
Okay, we'll do one more quick question, Nadia.
Yeah, so it was a comment from someone. I'm just going to read it out. It's not true to say that a laryngectomy patient cannot aspirate. If the patient has a TOF, which currently most laryngectomy patients qualified for, a TOF to improve quality of life for communication, either primarily or secondarily, the TOF can allow a patient to aspirate, unfortunately.
Yeah,
and just explain TOF again, would you please?
Yeah, so it's a tracheal esophageal fistula. So it's that man-made hole between the trachea and the esophagus. And if you've got a leaking prosthesis, yes, you certainly can aspirate. That was a generalized term that theoretically a laryngectomy patient can't aspirate. I mean, you can also vomit and inhale, so you can aspirate that way. But I think, you know, as a standard, laryngectomy patients without a leaking prosthesis can't aspirate, as you can't hang yourself either, because you've actually removed the hyoid bone. It's just a generalized term.
And just very quickly for the totally new, what does that word prosthesis mean?
I'm going to cover that one, Julie, and I've got some images that will go along and explain what a voice prosthesis is. Okay,
well, look, thank you. So, Tracey, we'll see you again in a moment. Let me introduce Alanna, and she can become a big face on our screen. So Alanna Bowen is a speech pathologist, and she's completed a master's in speech and language pathology at Macquarie University back in 2008 in Sydney, and she's currently completing a master's in cancer science at the University of Melbourne. And Alanna has extensive public health experience, and she's very recently entered private practice. She also has a lot of experience with complex patients who've had laryngectomies, and she's attended the Advanced Surgical Voice Restoration course at Imperial College London in 2018. And I guess the one thing I do want to add is that Alanna has family experience. Her grandfather had a total laryngectomy in the 1990s, and she watched her grandmother provide care. So a warm welcome to you. Thank you.
Lovely. Thank you very much for the introduction, Julie. Let me bring up my slides. Wonderful. So thank you, Julie. Thank you, Head and Neck Cancer Australia, for having me here today. And thank you all for being here with us. Tracey's given us a really great overview of what a laryngectomy is and some details about post-acute care and the surgery itself. So the overview that I'm going to cover today is up on your screen. And from the poll, I can see that we have a really varied audience today. So my presentation is going to focus on some basic knowledge around stoma care, pulmonary rehabilitation, communication, swallow function, all after a laryngectomy. And I'm also going to provide some practical tips for people who have had a laryngectomy or for their family and carers, because I understand that for a lot of you, it is really difficult to access your teams at the moment because of COVID restrictions. My slides are a little bit word dense, but that is because they're going to be available to you afterwards. So please don't feel like you need to read all the words on the page. If there are any other health professionals out there who feel like their needs haven't been met through this, please feel free to contact Nadia at Head and Neck Cancer Australia or myself for some more targeted information. So let's get started. The role of the speech pathologist. As many patients will attest, the speech pathologist is often the meat in the sandwich of laryngectomy care. Our role begins at diagnosis and continues through to survivorship. At various points along our journey, we provide education, rehabilitation, and help with accessing appropriate services. The clinical role of the speech pathologist focuses around management of the communication device of choice, stoma care, humidification recommendations, as well as managing the swallow. So we're going to begin with stoma care and humidification. Like most recommendations we make, no two patients will ever have the exact same needs. Given that the stoma is the only way for a person to breathe following total laryngectomy, it's vital that this is clean and open at all times. This is achieved by huffing or coughing, cleaning and wiping the stoma following a cough, removing any dried secretions, attending to humidification needs, using laryngectomy tubes and buttons as required. And just to highlight what Tracey has said, for this particular patient population, resuscitation is always via the stoma. The disconnection between the upper airway and the nose and mouth results in cold, dry air being inhaled via the stoma. So to counter this, humidification is required. And without the humidification, secretions become thicker and more difficult to cough out. The current gold standard is the use of HMEs. These are heat moisture exchange systems. These are cartridges that have a foam filter inside them, and they're housed over the top of the stoma by a base plate or a tube. The foam retains heat and moisture on an exhalation, which is kept within the system during the next inhalation. HMEs need to be used 24 hours a day, 7 days a week to achieve the maximum benefit to lungs and secretion management. There are other humidification options available, and these may be more beneficial for some people given individual circumstances. Just a note on nebulizers. Typically, these are not recommended for routine humidification, as the droplet size is larger than that provided by a humidification device such as an Airvo. And rather than providing humidification, nebulizers tend to induce a cough. Of course, a nebulizer will need to be continued for people who require medication via this route. Some tips for you about managing problems that come up with your humidification. To troubleshoot any changes to your secretions or increased coughing, check that the seal on your base plate is adequate. Ensure that you're changing your cassette every 24 hours and not reusing it. These must be thrown away. You may find that these changes to your secretions are caused by changes to the weather, or you may have an underlying illness that needs to be reviewed by your GP. Any coughing up blood usually indicates that your humidification is inadequate. So you need to discuss this with your team as soon as possible. However, if you find yourself coughing up fresh blood, you need to call an ambulance or make your way to the closest emergency department. Moving on to communication. The first communication option we're going to talk about is the voice prosthesis. And using a voice prosthesis results in tracheoesophageal voice. And this is the most common form of voice rehabilitation following a laryngectomy. To use tracheoesophageal voice, we use the voice prosthesis, which is a one-way valve. And as we've mentioned, it sits in a hole between the airway and the esophagus. And you can see it if you look in the little picture down the bottom. You've got the airway at the front, the esophagus at the back, and this little white bit here is the voice prosthesis. The voice prosthesis is one way to allow air through to make the voice, but to prevent food, fluid, or secretions being aspirated from the esophagus into the airway. Voice prosthesis management in Australia is typically carried out by a speech pathologist with additional training in the area. Voice is produced by occluding the stoma, which redirects air through the voice prosthesis into the back of the throat. And this causes the tissues to vibrate. It's this noise of the tissues vibrating that is the source for the new voice. Voice quality is dependent on the ability of the tissues to vibrate. So tissues and muscles that are too tight will result in a strained and high-pitched voice, while muscles that are too lax will result in a weak and breathy voice. There are many different voice prostheses available. However, they all use the basic principle of a one-way valve. And this is a little video to demonstrate the use of a voice prosthesis.
Hello everybody, my name is Darren O'Connor. I am a Larry. I'm also a larrikin. I have survived 3 head and neck cancers in the past 7 years and living life to the fullest. Thank you.
You should be able to view the voice prosthesis when looking through the stoma. It will be sitting on the back wall of the airway. However, visibility may be impacted by the individual's anatomy and the placement of the voice prosthesis. So in the image on the left, you can see that we have what is called an indwelling voice prosthesis and that it sits a little bit lower. So the view of this voice prosthesis is obstructed by the small stoma. On the right, we have a non-indwelling voice prosthesis, which shows that the white tag makes it much more easily visible, as does the size of the stoma. Tips for managing your voice prosthesis. Leaking through the voice prosthesis isn't always an indicator for change, so try to manage it with cleaning first. If this doesn't resolve it, contact your speech pathologist for a review, as there may be issues with candida, your swallow, or the voice prosthesis may have simply reached the end of its life. Leaking around the voice prosthesis often points to other problems which are impacting the health of the tissues that surround the prosthesis. These need to be addressed by your team. Changes to your voice quality can indicate that the voice prosthesis is blocked or that the muscles that vibrate to make the voice have been impacted by residue from swallowing. Try cleaning the voice prosthesis first, and if this doesn't help, contact your team. A sudden lack of voice is highly suspicious for the closure of the hole that the voice prosthesis sits in, and this needs to be reviewed by your team as soon as possible. Please ensure that you've got this useful backup equipment to manage any central leaking through your voice prosthesis, a voice prosthesis plug, and thickening powder or fluid. The hole that the voice prosthesis sits in is much like an earring hole, and it will typically close over if there isn't anything in there. If the voice prosthesis is dislodged, we need to save the hole, otherwise the person will need to return to theatre to have a new one created. I'm going to briefly talk you through how to manage if your voice prosthesis is dislodged. Firstly, check in the mirror that there's no voice prosthesis visible. Find your torch and spare catheters. Start with the catheter that is closest in size to your voice prosthesis, not the end of the catheter that will be stuck to your neck. Use a small amount of lubricant on the tip of the catheter and insert it into the hole where the voice prosthesis sits. Make sure that you're aiming for the small hole on the back wall of the airway, not generally advancing it into the stoma. If you can't insert this catheter, go down in sizes until you find a catheter that will insert easily. The size and fit of the catheter will depend on the tissues and how long the voice prosthesis has been dislodged for. Leave only enough catheter out so that you can securely tape it to the neck. Check that there isn't any leaking of fluid around the catheter when you swallow. If fluid leaks out, you can try a larger size. Find your voice prosthesis. We need to know where this is, otherwise there is a possibility that it is in your lung. If you can't find your voice prosthesis, you should have an X-ray of your chest or a CT to determine that it is not in your lungs. And finally, alert your team. Moving on to communication with an electrolarynx. An electrolarynx is a device that creates vibrations, and this is used as the sound source for speech. The device needs to be held against soft tissues in the neck to aid the transfer of vibration into the oral cavity, where lips, teeth, and tongue then turn it into the speech sounds that we know. Most people know this communication option due to the output sounding robotic in nature. I'm going to play you a little clip, hopefully.
Hi there, my name is Graham and I had throat cancer almost 7 years ago, and without a lung I wouldn't be able to use this box. A working on it, and I can have a conversation, I can attend meetings and participate in them, and I can also talk on the telephone and be understood.
There are 3 main devices on the Australian market. They all have the same underlying mechanics, however have slightly different tones and features. It's individual preference as to which one works best for you. Some tips for using your electrolarynx. You're going to get the best transfer of vibration if you use the softest tissues that you can find in your neck. So experiment with the position, change hands, try both sides of your neck, and ensure that the plate of the electrolarynx is held firmly against the tissue. Slowing your rate of speech and over-exaggerating will help with clarity, and it's going to feel really unnatural to begin with, but the degree of over-exaggeration is going to reduce with time and practice. Esophageal speech. Now I'm going to be really honest up front and say that I have no experience in teaching esophageal speech and absolutely no idea how to teach esophageal speech. Since the invention of the voice prosthesis, esophageal speech has really taken a back seat. Esophageal speech produces the same sound as tracheoesophageal speech, the voice that we use with a voice prosthesis, because it is the same muscles that are vibrating. However, it's a different method to get the air there. The method involves using the back or the base of the tongue to push against the back wall of the throat, causing air to be injected into the area. The air then vibrates the same tissue that it vibrates when you use a voice prosthesis. This sound then travels through the mouth and the lips, teeth and tongue shape it into speech. In my clinical experience, most people learn how to use esophageal speech for single words or short phrases by accident. I've found an example of esophageal speech with many thanks to the ATOS YouTube channel.
Hello. My name is Dora, and I have a voice.
My very small tips for esophageal speech. Try having a couple of mouthfuls of carbonated drink to encourage a burp. Tune into that sensation because that is the sensation that you want to replicate by swallowing air to get the burp started. And if you happened to make any sound without occluding your stoma, again, tune into this sound and over time, try and turn these single sounds into single words and build on them from there. Moving on to swallowing. Logic would tell us that swallowing after a laryngectomy should be easy. The food and fluid have only one place to go, but this isn't the case. Due to the removal of the voice box, the muscles that are responsible for actively moving food and fluid through the back of the throat are no longer able to do their job. This typically results in a more passive and weaker swallow. While it's not possible to choke, food and fluid can get stuck along the esophagus, and it's worthwhile remembering that no amount of suction is going to move this because the suction is going into the stoma or the airway and the food is stuck in the esophagus. Despite this, aspiration can still occur through or around the voice prosthesis if there is one present. Many things can contribute to reduced swallow efficiency, including the contour of the tissue, the strength of the base of tongue at the beginning of the swallow, the position and size of the voice prosthesis, the degree of tightness in the tissues, and effects of radiotherapy. Some tips for your swallow. What is easiest to swallow is usually discovered through a lot of trial and error. Typically, softer foods with a higher degree of moisture will result in less effort and less time to eat, and less occurrences of food sticking in the esophagus. Ongoing or sudden severe changes to your swallow require further investigation, and your team may suggest a barium swallow or a video fluoroscopy. It would be completely remiss of me not to touch on COVID, given the situation that a lot of us find ourselves in at the moment. COVID has resulted in a significant change to the way most services are able to continue to monitor people who have had a laryngectomy. There is a reduction in face-to-face appointments and an increased reliability on phone and video reviews. Because of this, it's vital that every person remember that they are their own expert in their laryngectomy. You need to know what is normal and what is not normal for you, and you need to escalate any changes to your team. It is the responsibility of your team to acknowledge your expertise, listen to your concerns, and triage these appropriately within the guidelines. Similarly, you need to be able to access the equipment required to maintain your safety if you are admitted to hospital. For example, some COVID protocols may prevent the use of an airvo if you are admitted to hospital. However, you need to ensure that you have access to steam as an alternative, and also more frequently, so that you can maintain adequate humidification while in the hospital. Ensuring that you have been referred to speech pathology will provide another advocate for your care. A significant change also is the time in which voice prosthesis changes can be arranged. Now, we can all appreciate that this is inconvenient and incredibly irritating to have a leaking voice prosthesis. However, many services have had to make changes to the location of where they change their voice prostheses. They need additional cleaning and PPE, and often these areas are shared with other disciplines. All of this means that access is much more limited compared to pre-COVID times. So while a leaking voice prosthesis is something that needs attention, you need to be able to problem solve at home and use your plug or thickener to manage the leak while you wait for your appointment. I also wanted to touch on the idea of COVID testing in people who have had a laryngectomy. Sampling via the stoma is recommended across most nationally endorsed documentation for people who have had a laryngectomy or a tracheostomy. And this is because the upper respiratory tract, which is sampled via the back of the nose and the throat, doesn't have a significant amount of airflow and therefore has reduced contact with aerosols. In a quick scan of the literature from 2020 and 2021, there have been several reports of false negative COVID-19 results in people who have had a laryngectomy where they have only been sampled via the nose or the back of the throat. And I provided 2 references there just as a starting point for anybody who is interested. Finally, I want to end with information on when you must go to your emergency department. So while it's good practice to keep your team informed of any and all changes to your care needs, often these don't require you to see your team in an urgent fashion. The scenarios above are ones that require you to either contact your team ASAP, call an ambulance, or get yourself to an emergency department. And just for clarity, I'm going to read through these. Coughing up fresh blood from the stoma. Changes to the size and shape of your stoma where it is affecting your ability to breathe. Secretions that are blocking your stoma and affecting your ability to breathe. Changes to the consistency of your secretions where you're coughing up thick and sticky mucus plugs, and especially if these are affecting your ability to breathe. Being suddenly unable to voice or having a very quick deterioration in your ability to voice with your voice prosthesis, and more so if you have dislodged your voice prosthesis and you are unable to insert the catheter or a new prosthesis if you have been educated to do so. That's a wrap for the nutshell version of laryngectomy care from a speech pathology perspective. Thank you all very much.
Alanna, absolutely superb. And I want to remind our viewers that you will be able to watch all of this again at your own pace because it will be sent to you and be on the website. Nadia Rosen, some questions, please, before we return to Tracey.
Yeah, thanks. Let me just make sure I'm off mute. And I have to say I'm in Sydney and there's a very big storm overhead and lots of thunder and lightning. So that's if you hear any noise in the background. Someone just made a comment, a leaking voice prosthesis is the single biggest impact on the quality of life. Someone else would specifically like to know, are all speech pathologists trained to maintain and provide care with a voice prosthesis?
I completely appreciate that, yes, a leaking voice prosthesis would be an incredibly big impact on quality of life. That's why I wanted to provide those 2 quick things that you can have in your back pocket to help manage that while you wait for your team to be able to help you out with your leaking voice prosthesis. So your plug and your thickening powder or some thickened fluids. Sorry, Nadia, can you tell me the other part that you just said?
Are all speech pathologists trained to maintain and provide care of voice prosthesis?
The short answer is no, but the caveat to that is individual health services have different programs in place. So you might find that all speech pathologists in a department have basic care, so they can potentially clean a voice prosthesis, check for a leak, check for a dislodgement, but they won't all be trained to insert a voice prosthesis. That's definitely an advanced skill that requires extra training.
Okay, and another one, if the voice is low in volume and breathy, is it possible to improve the muscles? As you described, they are the cause of a low quality voice.
Unfortunately, there's not a lot we can do to change the tone of the muscles by way of exercise. So we can manipulate the muscles. We might try putting some pressure on different points of the neck to see if we can get the muscles closer together so that they vibrate and make a stronger sound. We might be able to turn to our ENT colleagues to see if there's anything surgically that can be done. But in terms of exercises to rehabilitate those muscles, no, we can't do anything to strengthen them.
Okay, thanks. And the final one, my neck feels like a metal collar is around it most of the time. At night, it's worse. I'm doing the daily exercises. So is it a time thing? Without knowing people's full story, it's a little bit hard to give a very good answer, but I would suggest that this person has probably had some radiotherapy as well along the way. And what we know is that radiotherapy, unfortunately, does tend to make things tight for a long time. The best you can do is follow your physio's advice, do the exercises, do the stretches, and hopefully that with time, that sensation will become less, and that the physio will adjust those exercises as need be.
Look, thank you so much. And Alanna, we'll welcome you back for our final Q&A. And what I'd like to do now is welcome back Tracey Nicholls, who's going to talk about life after the surgery. So we'll see you a little bit later. Welcome back, Tracey.
Thank you. There we go. How's that look?
Perfect.
Excellent. Excellent.
Okay, great. Thank you and welcome back. Here we go. So there we go. This once again too is just up there so that you can have a look at that. I don't want to go through all of these post-treatment side effects that you may or may not experience, and there's varying levels of each and every one of these that could be pertinent to someone that's just had a laryngectomy and then radiation or chemotherapy treatment to follow. Dental problems are very common, especially after radiation treatment, and that's because of the reduced blood supply to the maxillary and the mandibular bones, so your jaw bones. Radiation tends to knock off some of the littler vessels that supply these. There's also what it does, it decreases the amount of saliva and also that chemical composition. So it becomes a lot thicker and a lot less. And what this does, because of that chemical composition, it changes what it does in your mouth. So there's changes in the bacterial load. It doesn't knock off the bacteria that lives in your mouth. So what that does long term can cause increase in dental caries and soreness and periodontal inflammation. So there is a video that Julie did that lives on the Head and Neck Cancer website as well, a series of videos that actually looks into all of the dental issues following radiation. But it is really important to keep up good mouth care and good teeth care, and just cleaning, flushing and using a fluorinated toothpaste really, really helps. So thyroid, that's another thing that both surgery and radiation can do, can knock off the function, or it could be removed during your surgery. So it's really important that you have that checked by your GP once a year, once it's stable. Lymphedema. Now, lymphedema is that due to the surgery and the radiation, that those lymphatic chains have been moved or destroyed, and they're kind of the filtering units that live in all parts of your body, but especially in the neck when that's removed, and that causes that lymphedema or swelling that most head and neck cancer patients that have had treatment experience. And treatment can include just manual lymphatic drainage and massage by trained physiotherapists or specialists. Sometimes compressive garments can help. Low-level laser, and there's more and more evidence out there supporting the use of low-level laser in treatment for lymphedema. Remedial exercises, and of course taking really good care of your skin, and often, you know, just time, just letting things settle down and the drainage pick up again a little bit down the track. So neck tightness and swelling obviously is due to the lymphedema, and this can improve overall with time and massage and treatment. But sometimes the physiotherapist might recommend that you use things like wedge pillows, which is a high density foam. These are reasonably expensive, around about $180 worth. Otherwise, just lifting the head of the bed by using bricks or some blocks may help. Sleeping can be difficult, and trying to find what actually works for you. I've got a patient that sleeps in a recliner because he can't lay down anymore. I think too, just very, very quickly, and this is certainly not an exhaustive list of the costs of being a laryngectomy. Those voice prostheses that we've just talked about are around about $400 each. Some will last 6 weeks. Some can last 12 months. It just depends, and what one can last you 12 months, 1 year, and the next year you can go through 3 or 4. So they're around about $400 each. The HME and base plates and filters, they work out around about $8 to $10 a day. Bibs and stoma buttons, $10 each. To set up that humidifier, the Fisher Paykel humidifier at home, is around about $2,500, and then about $150 in consumables each month. Nebulizers, suction units, everything that we take for granted, breathing through our onboard nose and humidifying system that we are left with, a laryngectomy patient can spend or need to spend between $8,000 and $10,000 a year. Travelling, yes, you can travel, but it's really important that you plan ahead. If you're flying, wear a HME or even moisten the Buchanan bib to provide a little bit of humidity. I think it's really important that you inform the flight attendants when we get back to flying that you may need to write to communicate. Because of the background noise of the plane. The humidity, the low air humidity certainly can dry out the trachea and lead to mucus plugs. And then take all a summary of your medications, the surgery that you've had, the medical diagnosis as well. Have all that on hand next to you, then everything else that you would normally do. Drink lots of water, avoid alcohol, caffeine. One of the things that would be really handy is having this portable nebulizer as well, so that can give you some moisture as you're travelling. Smoking. Individuals with head and neck cancer should receive counselling about the importance of stopping smoking. Smoking is a major risk factor in head and neck cancer, and the risk in smokers is further enhanced by the alcohol consumption. Smoking can also influence your cancer prognosis, and smoking during and after radiotherapy can increase the severity and duration of the mucosal reactions. It can worsen the dry mouth, and it also can compromise the outcome. Patients who continue to smoke while receiving radiation therapy have a lower long-term survival rate than those that try and give up and don't smoke. Intimacy. Cancer often has a profound and enduring impact on intimacy, affecting both patients and their partners. Most healthcare professionals in cancer and palliative care struggle to address these intimate issues with their patients in their care. And most of the time is because we're not trained in it, and also because we deal with the immediate problem, which is dealing with your cancer. But I think some of the most question that I often get asked, is there any dangers for my partner? Will my partner catch my cancer? And the answer to that is no. And then it's questions around how they cope with feeling very disfigured. There's Dr. Amanda Horden who lives in Victoria, and she's done extensive work on around sexuality and intimacy in cancer and palliative care, and that's her details and links there. Anxiety and depression, total laryngectomies are more likely to become isolated due to the loss of communication, social interactions, loss of employment, and that physical disfigurement. I think my advice would be learn to recognise the signs. When things start to change or make you anxious or thoughts become negative, identify it and talk to your doctor, and please seek help. Survivorship and recovery. A cancer diagnosis has an impact physically, emotionally, socially, financially, spiritually, and sexually. Head and neck cancer affects every aspect of one's being. All treatments used have an impact and a consequence. Head and neck cancer leaves both visible and invisible scars. Some patients even report feeling rejection from people. Everyone's cancer journey belongs to them, and each will be very, very different. Just briefly, almost done, current issues and progress is that we've been able to help updating the training program, the Resus for Alternate Airways, with the Victorian Ambulance Association. Mike George, who you'll meet shortly, has recently released a video about what it is to be a laryngectomy. Head and Neck Cancer Australia, and I'm sure Nadia will allude to this as well. We've got a parliamentary breakfast booked for the 30th of November, and that's to raise awareness Australia-wide about head and neck cancer. And also about the inequity in funding. I'm not sure if any of you are aware, but all of the eastern seaboard of Australia, Queensland, New South Wales, Victoria, and now Tassie, actually have funding for their laryngectomies. Each of the states have different sort of packages, but that funding starts at around $5,000 to $6,000 for consumables for the laryngectomies in those states. South Australia, Western Australia and Northern Territory do not have any funding whatsoever. One thing also that's been amazing, and just to see how it grows, is Mike George has started the Larrikins, which is a website. They dial in weekly. It's kind of drinks at 4 on a Friday afternoon, and that has just built a group and a camaraderie between laryngectomies that's just amazing and very touching. He's done an incredible job. Also, different things like seatbelt covers and windscreen stickers are now available that you can use, pop on in your car or on your windscreen to alert any emergency responders that you are a neck breather. Websites and different links that you may find useful, but that's all from me. Thank you, Julie.
Again, thank you so much, Tracey. Just absolutely marvellous. Ladies and gentlemen, we don't have a long time left, but let's take 1 or 2 questions, and then we'd love to introduce you to a short video made by our ambassador, Mike George, who's been referred to. So over to you, Nadia. Thank you.
Thanks, Julie. So just on the funding, someone would like to know, are there any subsidising programs, for example, the NDIS, that can help cover the costs of the consumables?
NDIS is very precarious, and mostly because you have to be over 16 and under 65 for a start, but you also have to have a disability, and currently not a neck breather or a tracheostomy patient is not a disability. I mean, you might have a broken back or paralysed legs, and then therefore you meet the funding requirements for NDIS. But as it stands at the moment, no. A laryngectomy patient, it's very difficult to get a disability funding. Alanna, I don't know if you've got anything else.
Yeah, so just NDIS is quite the tricky one. Not to say that it is impossible, but it is along the lines of the laryngectomy or tracheostomy in and of itself is not enough to qualify as a disability. Speech Pathology Australia had a great head and neck cancer specific chat with some speech pathologists a couple of months ago around NDIS and funding for this group of patients. So if there are any speeches out there, you'll find that on the Speech Pathology Australia website, just some tips and some more information. And
Nadia, that could well be something to raise with our politicians federally.
Yeah, it's on the list. We've got a long list for them. So question from somebody who has had a laryngectomy. We need emergency resuscitation protocols. What else do you think needs to be done to ensure safety for people who've had laryngectomies?
Let's go to each of you, Alanna. Do you want to go first?
I think that the first thing is making sure that first responders are aware of what the anatomy means. So updating the Ambulance Victoria education is fabulous and well overdue, and I'm very hopeful that that filters through to the other states as well. I think it's also to just, I've always been quite strong on the idea that you are your best expert. You are your expert, and no matter what medical professional you walk in front of, 9 times out of 10 you're going to know more about having a laryngectomy than what they do. So be confident in that knowledge, explain to them what they don't understand, be the person to provide them with that education for the next person that walks through their door.
Would you like to add anything, Tracey, on safety?
I think, yeah, that's absolutely spot on. And I think there's movement afoot for the work that's been done with Ambulance Victoria to carry across states, which is really exciting. And I think it's just about getting that knowledge out there, and that, you know, I don't know how many people I've met and I would talk about laryngectomy and they go, well, what is that? So I think, you know, it's about advocacy and just getting the knowledge out there about what these patients are.
Nadia, could we play the tape that has been created by Mike George? We are going to finish at the scheduled time, but I don't want people to miss Mike, so I'll be quiet and here's Mike.
Hi, I'm Mike George. I'm a laryngectomy, a Larry or a larrikin. I was diagnosed with cancer on my larynx in April 2016, and I then had a total laryngectomy in January 2017. Despite the prior preparation with my surgical team, I was shocked when I first looked in the mirror. My cancer was gone, and I was now a neck breather. With the care of my specialist medical team and speech pathologist, I quickly learnt to breathe through my neck stoma and talk using the voice prosthesis, also to maintain and care for my stoma and my new VP, along with regular medical maintenance, be it a VP change or the occasional procedure. I'm now able to live a good new life. Anybody who has had a laryngectomy will tell you it's a life-changing event, and no two Larrys are the same. They'll experience different bumps and challenges along the way, and some longer than others. However, most can and do resume a new normal life. Large gatherings and noisy rooms present a challenge to be heard. You just adapt. It can also impact your social life, your activities, work, relationships, friendships, and your confidence. Because the stoma is so obvious, I've learned not to be shy about explaining it. I find this helps. It generally makes people more comfortable and at ease, also more aware too. You adjust to your challenges over time as your confidence grows, and family and friends also adapt too. I quickly returned to my main passions, including overseas travel and racing historic cars. Being prepared is also important as a Larry. I always carry my Larry travel kit with spare backplates, HMEs, tweezers and a torch, etc. I have car stickers and seatbelt covers to make others aware I'm a neck breather. I also carry a spare VP on longer trips. Support of family and friends plays a big role in regaining confidence and returning to a new normal life. Most Larrys I know have resumed work or hobbies, sports and other activities. Over my journey, I've met and shared experiences with many Larrys in Australia and overseas too. We formed a group called the Larrykins who support each other and share tips based on personal experiences. We also advocate on behalf of laryngectomies too. Larrys and their partners have a regular Zoom chat and drink session to share in a social environment. This support has made a really big difference to many Larrys and their partners too. Our aim is to enjoy life and continue to have fun. The Larrykins will keep raising our voices and enjoying life. Cheers.
Absolutely fabulous. I hope Mike's watching, and congratulations and thank you so much. I'm wondering, Nadia, so that we get the maximum number of people answering our poll, should we do our final poll and then maybe if there's one more question and then we'll make our final farewells?
Absolutely. So I'll just get that up.
So ladies and gentlemen, the poll is coming up. There's 2 questions and I'll read it. So this is our final closing poll. Question 1. What was the most useful thing you learned today? And you can click more than one. What is laryngeal cancer and treatment? Role of the speech pathologist? Stoma care? Types of communication? Troubleshooting tips? Living after a laryngectomy? What to do in an emergency? When to ask for help? Please click those that you found most useful. I'll now go to our second question. I feel more confident in looking after myself or caring for a person with a laryngectomy. Just one choice here, please. Yes, no, somewhat. Well, if you could complete your responses and then hit submit. And I'll ask Nadia, our whiz, to put up the answers so that I can read them to you.
Press the magic button. Okay, I think most people have nearly finished. So I'll end it.
And the answers, what was the most useful thing for you that you learnt today? 24%, what is laryngeal cancer and treatment? Role of speech pathologist, 29%. Stoma care, 44%. Types of communication, 29%. Troubleshooting tips, 48%. Living after a laryngectomy, 47%. What to do in an emergency, 44%. When to ask for help. And just the final one too, I feel more confident in looking after myself or caring for a person with a laryngectomy. 81% said yes, 1% said no, and 18% said somewhat. So thank you so much. It's great to get that immediate feedback. We will also send you a survey where you can give us more detailed feedback. And that is just so important, ladies and gentlemen, because I know Nadia and the team look very closely at what you say. A reminder that our final in this series will be in December. And now I'll hand back to Nadia to formally thank everybody. And I encourage deaf sign clapping.
Thanks, Julie. And well, firstly, again, thank you everyone for joining, and thank you, Alanna, and thank you, Tracey and Julie, for being part of this, because we certainly wouldn't be able to host these webinars without your expertise. As Julie said, we'll send out a short survey after the event, and we'd be grateful for your feedback. It helps inform the topics that we cover in future webinars. We'll also be sharing a recording link. So if you're a healthcare professional and you'd like to look at this in future or share it with a colleague, that will be available on our website. We're a fairly small charity, but we're determined to save lives by raising awareness about head and neck cancer so people know what the signs and symptoms of head and neck cancer are and seek early advice from their GP or dentist. As Tracey mentioned, we're hoping to host a parliamentary breakfast in Canberra at the end of November. This will be the first time that people with head and neck cancer have had a voice in Canberra, and we'll specifically be asking for funding similar to other more common cancers to raise awareness in the general public and amongst GPs and dentists, and also to fund for improving patient care and education and research. On the point about HME funding, as Tracey said, South Australia and Western Australia still don't have funding for HMEs. There's a lot of work being done within the community, and if you're interested in being involved in raising your voice, please let us know and we'll put you in touch with the people who are actively advocating to get funding in those states. We encourage everyone to join our virtual choir that's happening in October. Alanna is our expert speech pathologist who is part of that choir. We'll be recording a Christmas carol, and no, you don't have to sing. You can clap, you can dance, you can hold up a sign. It's very inclusive. We will be launching that song at our parliamentary breakfast. The aim of it is to raise awareness of head and neck cancer, and we're also hoping to get some media coverage. We'd love you to join in, whether you're a healthcare professional, a patient, a former patient, or a family member. Everyone is welcome to join in. There's a link on our website. In the meantime, you can follow us on social media, sign up for our newsletter to keep abreast of our activities. Thank you again all for joining this Friday afternoon. Wish you all a wonderful weekend, and thank you again to our speakers. We're very grateful.